Can we start? Okay, we can start now. So today we are going to discuss some high-yield MCQ points as well as some theory, some amount of high-yield theory in relation to the chapters CNS and CVS. Okay, so let's start with the CNS. So we can start with the classification of nerve fibers. Okay, we can classify nerve fibers broadly into 5 types. Means it can be classified according to 5 reasons. First is depending on the structure. Depending on the structure of the nerve fiber, it can be classified as myelinated and unmyelinated or non-myelinated fibers. So myelinated, as we all know, as the name indicates, it is covered by the myelin sheath, and non-myelinated, it is not covered by the myelin sheath. And depending on the distribution of the nerve fibers, they can be classified into somatic and autonomic or visceral. Somatic, it supplies the skeletal muscles, and autonomic or visceral, they supply various internal organs of the body. And the third type is depending on the function of the nerve fibers. They can be motor or supplying the muscles mainly, and sensory or the afferent fibers. Okay, motor or efferent and sensory or afferent fibers. And again, depending on the neurotransmitters, they are releasing for the signal transmission by the neurotransmitter. Depending on the neurotransmitter, we can divide into adrenergic, cholinergic, dopaminergic, like according to the neurotransmitter that is present. And depending upon the diameter, we can again classify into A fibers, B fibers, and C fibers. A fibers can again be divided into A alpha, beta, and delta fibers. Alpha fibers, they are having the largest diameter. C fibers, they are having smaller diameter. And among this fibers, only the C fibers are unmyelinated fibers. Okay, that's about the classification of nerve fibers. So basically our pain impulses, according to dentists, we are concerned, our important fibers are A delta fibers and C fibers. Okay. So pain impulses, they are believed to be conducted into the CNS by 2 types of nerve fibers. That is the A delta fibers and the C fibers. Okay. We can compare this A delta fibers and C fibers. They can be imagined as A delta can be imagined to as an adult fibers, and C fibers can be considered as children fibers. So A delta fibers, they are myelinated, i.e. they are having a proper dress. Okay. Myelin can be considered as a dress for these neurons. So A delta fibers of the adult fibers, they are covered up properly. So they are myelinated, whereas children, they are not usually covered up properly unless, okay. So they are unmyelinated fibers. We can remember this properties of A delta fibers and C fibers like this. Okay. Also, we know that sharp pain, we adults can appreciate the sharp, proper localization of the pain. Fast pain, etc. can be appreciated by the adults more. So, A delta fibers, that is concerned with the sharp localization of the pain. Whereas C fibers, they are concerned with the slow, dull pain. Okay. Pulp fibers, they are usually having the C fibers. Also, the local anesthesia is mainly effective on the C fibers. Okay. So, these are the main properties of the pain fibers, that is the A delta. This is in overlap with the pedodontics also. Okay, in pedo also we are learning about the A delta and C fibers in relation to the pulp. Okay, so A delta fibers, they are responsible for the temperature. First of fast pain is concerned with the A delta fibers, and they are conducting more faster. Okay, adults are more faster than the children. So they are having more conduction velocity that is associated with the myelination. Since A delta fibers are myelinated, they are having more conduction velocity. The velocity is more in case of A delta fibers, and whereas in C fibers, the conduction velocity is less. Also, the odontogenic pain. from the pulp is also associated with the C fibers. LA is mainly affecting, the action of LA is mainly on the C fibers. That's also an MCQ point. Okay. So now coming to the traumatic injury of the nerves, traumatic injuries of the nerves. So the traumatic injuries of the nerves, they can be divided into three. Okay. It can be remembered as NAN. NAN means neuropraxia, axonotemesis, and neurotemesis. So neuropraxia, this is according to the severity of the nerve injury. Neuropraxia is the mildest form of injury in which these nerve fibers as such are intact. There is no physical disruption of the fibers or anything like that. There is only a physiological paralysis of conduction, which is completely reversible, or complete recovery is possible in case of neuropraxia. And some amount of splinting of the involved areas in position is required for the treatment of neuropraxic injuries. And spontaneous recovery is almost always happen, will always happen. Okay. Next is somewhat more severe than neuropraxia, that is the axonotemesis. Then there is some amount of rupture of the nerve fibers, but the neurolemmal sheath is intact. So recovery is possible in case of axonotemesis also, since the neurolemmal sheath is intact. So what is neurolemmal sheath? It's a coil of Schwann cells covering the axons. It is seen in both myelinated as well as unmyelinated nerve fibers. Okay. So also you know that what is endoneurium, perineurium, everything you know, I think you know. Endoneurium is the covering of the connective tissue, covering of the nerve, single nerve fiber is called endoneurium, and a group of nerve fibers or the fascicles that are covered by the perineurium, and epineurium is the whole nerve fiber is covered by the connective tissue sheath that is called epineurium. Whereas neurolemmal sheath is outside the nerve, which is consisting of the Schwann cells in peripheral nervous system, whereas in central nervous system, it is concerned with the oligodendrocytes. That's also an MCQ point. Okay. The next injury is the neurotemesis. Neurotemesis is the severe form of injury in which complete or partial dissection of the nerve will occur. So it is usually occurring due to some kind of penetrating wounds. So we cannot expect complete recovery in case of neurotemesis. Okay. So that's about the traumatic injuries of nerves. This classification is called Seddon's classification. Okay. So it's a pictorial representation of the Seddon's classification of nerve injuries. Here in neuropraxia, we cannot appreciate any nerve fiber damage, whereas in axonotemesis, there is some amount of nerve fiber damage, but there is the neurolemmal sheath is intact. Here in neurotemesis, everything is disrupted or complete transaction of the nerve fiber is occurring. Now, coming to the changes during the degeneration of nerve fibers. Degeneration. Okay. First is the Wallerian degeneration. Wallerian degeneration, it indicates the degenerative changes in the distal cut end of the nerve fiber. That is, away from the cell body, the distal cut end of the nerve fiber is undergoing the degenerative changes. Okay. That is, in Malayalam, we know that the distal part we can consider as wall. Okay, in Malayalam. So, Wallerian degeneration. You can remember why that way if you are a Malayali. Okay. Next is the retrograde degeneration. Retrograde degeneration means the degeneration is occurring at the proximal end. Along with the degeneration of the cell body, it is called retrograde degeneration. And these changes occur only up to the first node of Ranvier. Only up to the first node of Ranvier. That is what we call as retrograde. So in retrograde degeneration, the proximal cut end is undergoing degeneration along with the cell body. Next is the transneuronal degeneration. Here, if an afferent nerve fiber is cut, the degenerative changes occurring in the neuron with which the afferent fiber synapses, the neuron that is synapsing is also undergoing some amount of degenerative changes. That is what we call as trans. That is trans across the neurons. This degeneration is occurring. So it is called transneuronal degeneration. So what are the criteria for the regeneration of the nerve? There is some amount of regeneration occurring to dissected or whenever a traumatic injury is occurring to the nerve, some amount of regeneration can occur. So there are certain criteria to meet for the regeneration of the nerve. First is the gap between the cut ends should not be more than 3 millimeter. So the nerve ends, so the cut ends should be nearer. As far as possible, it should be nearer, i.e. the gap should not be more than 3 millimeter. And the nucleus of the nerve fiber should be intact. neural lemma, that is outer covering sheet of Schwann cells, should be present. And as neural lemma is absent in CNS, the regeneration of the nerve usually does not occur in CNS. That can also be asked as a new question. Okay. And the two cut ends should remain in the same line or in the same alignment. They should remain. Regeneration usually do not occur if the one end of the cut fiber is moved away. Then regeneration cannot occur. Okay. So these are the criteria for the regeneration of the nerve fiber. So this is basic structure of a axon. Okay. So this is the Schwann cells. They are producing the neural lemma, the outer covering. And here, where there is no myelination here, in a myelinated nerve, it is called node of Ranvier. Node of Ranvier is devoid of myelin sheath. So here, the conduction of nerve fiber is more. That's what we call as saltatory conduction. Now coming to the supporting cells of the nervous system. Supporting or the connective tissue supporting cells of the neurological cells. They are astrocytes. They are astrocytes and microglia, oligodendrocytes. Okay. Astrocytes, they are star-shaped cells. They are usually present in all parts of the brain, and usually they twist around the nerve cells and form the supporting network. And also, they are responsible for the formation of blood-brain barrier. Okay. Microglia, they are the macrophages of the nervous system. You have to know the macrophages of different systems. Like in liver, we have the Kupffer cells. Okay. Like that. In placenta, we have the Hofbauer cells. These cells you have to know. And next is oligodendrocytes. These cells form the myelin sheath around the nerve fibers in CNS. Whereas in PNS, it is the Schwann cells. That's also an MCQ question. Okay. Now, coming to the receptors. Receptors can be broadly classified into two types, extroreceptors and introreceptors. Okay, as the name indicates, extroreceptors are receptors which give response to stimuli arising outside the body. So, the examples of these extroreceptors are cutaneous, chemoreceptors, telereceptors. They are all extroreceptors. Whereas, introreceptors, they give response to the stimuli arising inside the body. For example, visceroreceptors, proprioreceptors. Proprioreceptors means something related to the proprioception also. That is changes in body, changes in position of a body, that is usually concerned with the limbs. So change in position is what we call as proprioception. So proprioceptors give response to the change in position of the different parts of the body. For example, sensory receptors serving the stretch reflex. That is mainly the muscle spindle. That is the position and movement of the body is regulated by the proprioceptors. That is regulated by the stretch reflex of the muscle. That is again concerned with the proprioceptors. So these are the different types of receptors. Many questions can be asked from this single table itself. Okay. So what are the touch receptors? That's a Meissner's corpuscles and the Merkel's disc. They are concerned with the touch. Pressure receptors are P4P, that is a Puccinian corpuscles. And cold receptors are basically K and cold. Okay. So cross end organ is associated with the cold perception. And warm, that is Raffinis end organ. And pain or nociceptors, they are basically, this is also asked multiple times. Free nerve endings, there is no particular receptors for pain conduction. Only free nerve endings are available for the pain conduction. Pain or nociceptors are mainly free nerve endings. Next is the telereceptors. Telereceptors are associated with special senses. Special receptors are called telereceptors. For example, hair cells of the organ of Corti are the receptors in ear. Rods and cones in retina of the eye. They are all telereceptors. Rods and cones, they are associated with the night vision as well as black and white vision. Color vision is provided by the cones. Okay. Also, daylight vision is associated with the cone cells of the retina. Visceroreceptors, basically stretch receptors, baroreceptors, chemoreceptors, and osmoreceptors. They are all visceroreceptors. Proprioceptors, basically receptors in the labyrinthine apparatus and Puccinian corpuscles, Golgi apparatus in the muscle. Okay, etc. are proprioreceptors. Now, what is synapse? That is the junction between two neurons is called synapse. So it is a physiological continuity between two nerve cells. That's what we call as synapse. So nerve conduction usually occurs from the transmission of impulses from one neuron to next neuron is by means of synapse. And the chemical mediator substance responsible for the transmission of impulse through a synapse is called neurotransmitters. There are different types of neurotransmitters also. So this is also very important. The classification of neurotransmitters. According to the chemical nature, they can be divided into amino acids, amines, and other chemical substances. Basically, amino acids, they are providing fast synaptic transmission. They can be inhibitory, they can be excitatory. Okay. For example, glycine, GABA, glutamate, aspartate, etc. So glutamate is having excitatory action, whereas GABA is having inhibitory action. Also, amines, they are involved in slow synaptic transmission. They can be inhibitory, or they are according to the chemical nature. So it can be inhibitory or it can be excitatory. For example, noradrenaline, adrenaline, dopamine, everything is involved in the slow synaptic transmission. Okay, they are associated with the autonomic nervous system. And others are acetylcholine, nitric oxide, etc. And based on the function, they can be excitatory like acetylcholine, noradrenaline, adrenaline, etc. Inhibitory like GABA and dopamine. Now coming to spinal cord. As we all know, there are 31 pairs of nerves associated with the spinal cord. So we have 8 cervical nerves and 12 thoracic spinal nerves. Lumbar spines are 5 and sacral 5 and coccygeal 1. Okay, so 31 pairs of spinal nerves are present. Now, we have tracts inside the spinal cord. So what is a tract? Basically, a tract means group of nerve fibers having a single origin, single course and single termination. It can be either ascending tract or descending tracts. Ascending tract, they are usually concerned with the sensory function, and descending tracts are concerned with the motor function. Okay. Ascending tracts means they are arising from the spinal cord up to the higher centers of the brain, and termination is in the any of the higher centers of the brain. Okay. So these are most important ascending tracts, and their functions are also mentioned. So we have anterior spinothalamic tract, which is concerned with the crude touch sensation, and lateral spinothalamic tract, that is concerned with the pain and temperature sensations. And spino-reticular, that is concerned with the consciousness and awareness, and spino-vestibular, that is associated with the proprioception. So we have to notice the terminology, how these tracts are named. So here, spino is the word coming first. That means the origin of this particular tract is from the spinal cord. So when spine comes first, that is an ascending tract. When it comes second, that means it is a descending tract, descending of motor tracts. Okay. So the main function of spinothalamic tract is to carry the pain and temperature via the lateral part. So spinothalamic tract, according to the position, it can be divided into anterior spinothalamic tract and lateral spinothalamic tract. So the anterior part is concerned with the pain and temperature sensations, whereas the lateral part is concerned, anterior part is concerned with the crude touch, and lateral part is concerned with the pain and temperature sensations. So next is the descending tract. It is associated with the motor system, i.e. association with the muscles. So they are coming from the higher centers of the brain towards the spinal cord. Okay. So the point of origin of this tracts or the descending tracts is the higher centers of the brain up to the spinal cord. So they are named like this: corticospinal tract, reticular. According to the position of origin, they can be named like this. So we have two types of descending tracts, basically according to the position. First is the pyramidal tract and extrapyramidal tract. Only one thing is involved in the pyramidal tract. Since it is passing through the pyramid of the medulla, corticospinal tracts are called pyramidal tracts. Rest all others are called extrapyramidal tract. Okay. So the pyramidal tracts are basically lateral corticospinal tract and anterior corticospinal tract according to the position of the tract. So as we already mentioned, these descending tracts are motor tracts and conscious control. Pyramidal tracts or the cortico. Pyramidal tracts are only the corticospinal tracts are called pyramidal tracts since it's passing through the pyramid of the medulla. And it is concerned with the conscious control of the muscles from the cerebral cortex to the muscles of the body and face. Whereas extrapyramidal tract, they are originating in the brainstem, carrying motor fibers to the spinal cord. Extrapyramidal tracts, they are originating from the brainstem. So the pyramidal tract, it controls the voluntary movement, and while the extrapyramidal tracts, they are involved in the motor control, the posture control, posture coordination, and the muscle tone coordination are done by the extrapyramidal tract, whereas the pyramidal tract, they control the voluntary movements. Next is basal ganglia. This portion is also very important. Many questions are asked from this particular portion. Okay. What is basal ganglia? They are scattered masses of gray matter. You have to remember one thing. What is a gray matter? Gray matter means that's a collection of cell bodies of the neuron is called gray matter. Whereas white matter is the axons. Group of axon part is called white matter. Okay. When inside the central nervous system or inside the brain, a group of scattered masses of gray matter, they are called nuclei. So basal nuclei is the more appropriate term for basal ganglia. Okay. Outside the central nervous system, we are calling a collection of particular collection of gray matter. Discrete collections of gray matter, they can be called as ganglia outside the nervous system. So basal nuclei is the more proper term. Also, basal ganglia can also be used, but the more appropriate term is the basal nuclei. And usually they form the part of extrapyramidal system and they consist of 3 parts. It can be asked like this, what are the parts of basal ganglia, or which of the following is not a part of basal ganglia? So you have to know what constitutes the basal ganglia. So what are the parts? First is the corpus striatus, substantia nigra, and subthalamic nucleus of the lens. These 3 are the parts of basal ganglia. Okay. So, what are the lesions or the disorders associated with the basal ganglia? There are many. First and foremost, most important is the Parkinsonism. That's a disorder associated with the destruction of substantia nigra. That's a part of basal ganglia. Due to the destruction of substantia nigra, which is having dopaminergic fibers. So, in Parkinsonism, what happens is the substantia nigra part of the basal ganglia is destroyed. That will lead to the deficiency of dopamine. That is causing the different manifestations of the Parkinsonism. Okay. Next is the Wilson's disease. Wilson's disease is due to the inappropriate usage of the copper or excess of copper due to some genetic disease. What happens is copper accumulates in different parts of the body, especially in eyes. Eyes, we have Kaiser-Fleschner rings are there. There are certain manifestations of the Wilson's disease. Along with the symptoms of basal ganglia lesions, this Wilson's disease patients, they are having hepatolenticular degeneration. That is severe liver damage is associated with the Wilson's disease. And also, we can see chorea. Chorea means abnormal involuntary movements. That is like Michael Jackson dance. Okay. Such movements are called sudden abnormal involuntary movements. Dance-like movements are called chorea. Chorea is mainly due to the lesions occurring in the caudate nucleus and the putamen. That is rapid jerky movements. Okay, that is what we call as chorea. Next is athetosis. Athetosis means slow rhythmic twisting snake-like movements, like a Bharatanatyam, like that. Classic dance moves are seen in athetosis. Whereas in hemibalismus, the arm, unilateral arm, either the right or left side, whichever. Okay. So involuntary abnormal movements of the arm are usually seen in hemibalismus. Balismus means it's not unilateral. Here hemibalismus is unilateral. Okay. So while walking, the arm swings widely. That is what we call as tingling movements are seen in hemibalismus. So here we can see, you can remember more nicely. This is chorea, that is Michael Jackson-like dance. Rapid, irregular, unpredictable, jerky movements. That is dance-like. And in athetosis, what happens is classical dance-like movements. Okay. Slow, breathing movements. Next is a hemibalismus, that is violent flinging of the arms. Usually these lesions, valismus is associated with the damage in the subthalamic nucleus. Athetosis, the putamen is damaged. And in chorea, caudate nucleus is damaged. Okay. Next is the functions of limbic system. So what is limbic system? Limbic system basically it involves the amygdala, hippocampus, hypothalamus, cingulate gyrus and basal ganglia. This constitute the limbic system. So what are the main functions of limbic system? It regulates the endocrine glands, the olfactory sensations, regulation of food intake, control of the circadian rhythm, and regulation of autonomic functions. These are all functions of the limbic system. So these parts, what are the parts of limbic system? That is amygdala, hippocampus, hypothalamus, cingulate gyrus, and basal ganglia. So this is basically the limbic system. And hippocampus is concerned with the conversion of the short-term memory to long-term memory. So in hippocampus, whenever there is a lesion in the hippocampus, what happens is patient can remember the past memories, but new long-term memories are not created. Okay. So there is anterograde amnesia for such patients having hippocampus damage. Now the special sensors. So rods and cones we have already discussed. What is called myopia or short-sightedness, it is corrected by the concave lens, and long-sightedness or hypermetropia, it is corrected by using the convex lens. Can be also asked. Now, the location of different taste sensations. Tip of the tongue is concerned with the sweet sensations, and the dorsum of tongue, that's the anterior part of the dorsum of tongue, is concerned with the salt sensation. And posterior part of the dorsum of tongue, it is concerned with the bitter sensation. Okay. And sides of the tongue, we can appreciate the sides sour sensation. So the threshold of bitter taste is very low. So we can appreciate a mild amount of bitterness can be appreciated since the threshold for bitter taste is very low. Whereas sweet taste, it has high threshold. And also organ of Corti is present in the tectorial membrane. That's the sensorial organ for hearing. Okay, these are about the special senses. So this question is asked multiple times. What is a test for color blindness? That is Ishihara's chart. It is a test for color blindness. So this is one of the, there are 12 figures are there for the assessment of which type of color blindness is present in the particular patient. Okay. Like this, different images, 12 images are there for the Ishihara's chart analysis. So now, what is dichromatism? It is a particular phenomenon in which the subject can appreciate only two basic colors. There are three primary colors or three basic colors, but the dichromatism patient, they can appreciate only two basic colors due to the presence of only, they are having two types of forms, and hence they can appreciate only two basic colors. That's what we call as dichromatism. So from this table also, this is also very important. Protanopia, red color cannot be appreciated. In deuteranopia, green color cannot be appreciated. We can remember as PR work. Okay. Protanopia, red color cannot be appreciated. Deuteranopia, green color cannot be. And tryptanopia, blue color cannot be appreciated. Trichromatism, all the three types of cones are present, but there is some misalignment in the function of this cones. That's what we call as trichromatism. All rest others, we are having only two types of cones. Now, coming to some MCQs in the CNS portion. First question, you have to just read the question and the options and form yourself an answer and then check for the answer I'm giving here. Okay. So pain is conducted by A alpha fibers, A beta fibers, A gamma fibers, A delta fibers. What's the answer? So pain is conducted by A delta fibers and C fibers also. Okay. Also, another question, that is pain sensation from the lateral extremities is transmitted by spinothalamic tract. Okay. Pain and temperatures is from the lateral spinothalamic and anterior spinothalamic. It is concerned with the pain sensation from the lateral extremities. Sorry. Lateral spinothalamic tract is concerned with the pain sensation, temperature sensation, etc. Okay. Also, the pathway of pain from the teeth and temperature is carried by the lateral spinothalamic tract. Next is group B fibers are present here. First option is intrafusal fibers of the muscle spindle, Golgi tendon apparatus, autonomic preganglionic fibers, spinothalamic tracts. What's the answer? Autonomic preganglionic fibers. So, nerve fibers having greater diameter and myelin sheath usually conduct faster. That you have already mentioned. Myelin sheath is present, the impulses will be conducted more faster. And by the nodes of Ranvier. Okay, by the saltatory conduction, myelinated nerve fibers are fast conducting nerve fibers. And group C fibers, they are very sensitive to the local anesthesia. Both A delta and C fibers conduct pain sensation from the skin as well as the deeper structures. So, alpha means larger. Okay, this is according to the diameter of the nerve fibers. Progressively, the diameter is decreasing. So, A alpha, they are myelinated. All are myelinated except the C fibers. A alpha, they are associated with the motor nerve or proprioceptive function, and they are having fastest conduction because of the more diameter, larger diameter. They are having the fastest conduction. A beta, they are reference for touch. A gamma, myelinated, they are intrafusal fibers of the muscle spindle. They are associated with the A gamma fibers. A delta fibers, they are reference for thermal and pain sensation. B fibers, which are associated with the autonomic preganglionic fibers. C fibers, they are unmyelinated. Only one is unmyelinated, that is the C fibers. Slowest conduction, afferents for pain, and postganglionic sympathetic fibers are usually C fibers. So, another question, abdominal visceral pain is transmitted by the sympathetic fibers. Next question, preganglionic parasympathetic fibers are. First option, somatic only. Second, parasympathetic. Third, sympathetic. Fourth, cholinergic. Answer is cholinergic. Okay. So, here we have to remember one thing. All the preganglionic fibers, that is either it can be parasympathetic, it can be sympathetic, or these two, preganglionic is here. In preganglionic fibers, only acetylcholine is the neurotransmitter. And also the postganglionic parasympathetic fibers also acetylcholine is the neurotransmitter. Preganglionic, it is acetylcholine only. And postganglionic sympathetic fibers, there are adrenergic fibers, there are cholinergic fibers also. But acetylcholine is a neurotransmitter, whether it is preganglionic, sympathetic or parasympathetic, it is preganglionic fibers are acetylcholine, uses acetylcholine as the neurotransmitter. Next, which of the following is not true for the myelinated nerve fibers? Not true. First, the options are impulse through the myelinated fibers is slower than non-myelinated fibers. Second option, membrane currents are generated at the nodes of Ranvier. Third option is the saltatory conduction of impulses is seen. Fourth is local anesthesia is effective only when the nerve is not covered by the myelin sheath. So answer is impulse through the myelinated fibers is slower than non. Usually the impulse passing through the myelinated fibers are more rapid than the non-myelinated fibers. That's the advantage of the myelin sheath. Okay. So these are the characteristics or difference contrasts between this myelinated and non-myelinated fibers. Here in myelinated nerve fibers, depolarization occurs only in the nodes of Ranvier. That's what we call a saltatory conduction. Okay. And non-myelinated, along the whole length of the nerve fiber, the depolarization is occurring. So the transmission is slower when compared to the myelinated nerve fibers. So here, action potential in myelinated nerve fiber, action potential jumps from one node of Ranvier to the other. Whereas in non-myelinated, entire length of the nerve fiber is carrying the depolarization of the impulse. And so in myelinated nerve fibers, we can see the saltatory conduction and it is more fast. And energy spent during the myelinated fiber impulse transmission is lesser when compared to the non-myelinated nerve fibers. So next question. Unmyelinated fibers differ from the myelinated fibers is that they, as you know, have no nodes. So in unmyelinated or non-myelinated nerve fibers, we don't have nodes of Ranvier. Okay. These nodes of Ranvier, they are having more amount of sodium channels in order to conduct faster. Okay. And the nodes of Ranvier, that is not covered by the myelin sheath. Next question. In CNS, myelination is carried out by Schwann cells, astrocytes, oligodendrocytes, microglia. What's the answer? In CNS, it is the oligodendrocytes, whereas in PNS, it is the Schwann cells. So what is myelin? It's a collection of lipids, fats, and proteins that sheets along the long extensions of neurons, that is covering the axons. The collection of lipids and fats and proteins, they are called myelin. So it considerably increases the speed of the impulses. So what's the composition of myelin? It's about 80% lipids and 20% proteins. Okay. So we have already mentioned about the saltatory conduction. So it's an autoimmune disease which is characterized by demyelination. Autoimmune, that is unknown etiology, or immune mediated or autoimmune causes associated with the multiple sclerosis, in which the impulse conduction is slowed due to the demyelination of the nerve fibers. Next question. The sensory receptors serving the stretch reflex are classified as. This we have already studied. The options are proprioceptors, nociceptors, exteroceptors, chemoreceptors. What's the answer? Proprioceptors. Okay. Next is following are extrapyramidal tracts, except only one tract is pyramidal tract, that is the corticospinal. Okay. So it's a simple question. Rest others are extrapyramidal tracts only. Now, next question. Projections from substantia nigra parts compacted to the striatum releases. Options are GABA, dopamine, glutamate, aspartate. What's the answer? Dopamine. Okay. So, these neurons are disrupted in which disease? That's a Parkinson's. Another question is neurotransmitter in nigrostriatal pathway is basically dopamine. Okay. So, dopaminergic neurons are located in several brain regions. For example, in nigrostriatal system, mesocortical system, etc. They are the dopaminergic neurons which are in action. Okay. So, in nigrostriatal system, it projects from the midbrain substantia nigra to the striatum in the basal ganglia, and it is usually involved in the motor control. And in most mesocortical system, it arises primarily in the ventral tegmental area and projects to the nucleus accumbens and limbic subcortical areas. Also, this dopaminergic neurons, they are associated with the pressure, pleasure, reward behavior, addiction, and psychiatric disorders like schizophrenia. Okay. This we have already mentioned. Due to the destruction of nigrostriatal pathway, this Parkinsonism is occurring. Another name for Parkinsonism is paralysis agitans. Next is hunger center of brain is. Options are hypothalamus, stria nigra, frontal lobe, temporal lobe. Answer is hypothalamus. So, what are the functions of hypothalamus? So, this hypothalamus, as we all know, it is responsible for the release of synthesis of releasing hormones, regulation of water balance, control of body temperature, center of hunger, feeding, thirst, and satiety, center for emotional and sexual function. These are all the functions of hypothalamus. Okay. Another question is temperature of body. It's controlled by hypothalamus. So, Also, the satiety center, which is in association with the hypothalamus, it is usually regulated by the blood glucose levels. This question, simple question. Lesions within the basal ganglia produce the following signs except. The options are hypotonia, tremor, hemibalismus, ethitosis. That's the answer is hypotonia. So, tremors are seen in basal ganglia lesions like in Parkinsonism, hemibalismus, ethitosis, that is classical dance-like movements. These are all associated with the basal ganglia lesions. Good. Tremors are also seen in the disorder of basal ganglia. This is also another question. Hyperkinetic syndromes such as chorea and ethitosis are usually associated with pathological changes in the basal ganglia complex. Next is intentional tremor is a feature of. You have to be very careful while reading the question. Here we are asking about the intentional tremor and not the simple tremor. Okay, so intentional tremor is a feature of. Options are loss of function of thalamus. Second is loss of function of hypothalamus, loss of function of cerebellum, loss of function of basal ganglia. The answer is loss of function of cerebellum. So, this is another question. Tremors on movements. Tremors on movements is seen usually in cerebellar injury. So, what are the functions of cerebellum? Regulation of tone, posture, equilibrium, regulation of coordinated movements, etc. are the functions of cerebellum. So, the cerebellar lesions, they cause disturbances in the posture, equilibrium maintenance, and movements. Also, the symptoms are occurring on the ipsilateral, or the same side of the body, the symptoms are occurring. Balance will be affected, equilibrium, posture, tone, etc., tone of the muscle, etc. are affected in cerebellar lesions. So, these are basically the disturbance in cerebellum can cause this type of disturbances. In tone and posture, that will be leading to atonia, hypotonia, deviated movement, pendular knee jerk, patellar tendon reflex. Everything is caused by the lesions in cerebellum. And disturbances in equilibrium like staggered, drunken-like gait. While standing, legs are spread widely. And the disturbances in movements like ataxia, asthenia, intentional tremor, nystagmus, dysarthria, rebound phenomenon, etc. are all caused by the lesions in cerebellum. Next is dorsal column caries. It's a part of the spinal cord. Fine touch, crude touch, temperature, pain. The answer is fine touch. Okay. So one thing you have to remember is dorsal column pathways are somewhat advanced pathways. So the complex sensations are carried by the dorsal column pathway, and the primitive or crude sensations are usually carried by the anterolateral system. Okay, so these are the advanced sensations like touch sensations securing high degree of localization of the stimulus. Also, the touch sensations requiring fine gradations of intensity. The modern sensations are associated with the dorsal column or the medial lemniscal system. Lemniscal system means it's a part of white matter. Okay. And phasic sensations like vibratory sensations, signal movements against skin, position sensations from the joints, at least the proprioceptive receptors are usually associated with the dorsal column pathway. And pressure sensations have to do with fine degrees of judgment of pressure intensity. Whereas in anterolateral system, there is a more primitive system. So variety of sensations are carried by anterolateral. More variety of sensations are carried by the anterolateral or the primitive system. Okay. Pain, that's a primitive sensation. Thermal sensations, tickling sensation, itch sensations are all primitive sensation. And crude touch, which doesn't require any particular fine localization is not needed for crude touch appreciation. And as also the pressure sensations capable only of crude localizing is associated with the primitive system, that is the anterolateral system. Next is the lesion to the ventrolateral part of spinal cord leads to the loss of sensations below the level of. The options are pain and temperature on the same side, pain and temperature on the contralateral side, proprioception on the same side, proprioception on the contralateral side. So the answer is pain and temperature on the contralateral or the opposite side. Okay, there are crossings of nerve fibers occurring in this particular level. That's why the pain and sensation, pain and temperature on the contralateral side is affected by the lesion to the ventrolateral part of the spinal cord. Okay, so any lesion of the androlateral part of the spinal cord, basically the androlateral ascending spinothalamic tract will lead to the loss of spinothalamic tension sensations like pain, temperature below the level of lesion on the contralateral side. Okay. So this is an ascending tract. Next is, this we already discussed, the processing of short-term memory to long-term memory is done in the options are prefrontal cortex, hippocampus, neocortex, amygdala. So the answer is hippocampus. Good. Next question. Dash is an example for rapidly acting neurotransmitter. Example is glycine. Okay. Somatostatin, calcitonin, glycine, we know that it's an amino acid neurotransmitter. It is acting very fast and rapid. Next, coming to the cardiovascular system. So, first of all, let's have a brief outlook on blood circulation of the heart. This is a very basic part of the cardiovascular system, but we have to know very well. And this part, if you are thorough with this particular part, then you can easily solve most of the MCQs related to this cardiovascular system. Okay, basically, we have the heart has two atria and two ventricles that we all know. Okay, so right atrium, which is, we are having a double circulation. So the blood of the body, the whole blood is traversing the heart 2 times in a particular cycle. Okay, via the lungs and the heart, this blood is circulating 2 times, and hence it is called double circulation. Okay, so right atrium is having 2 large veins. First is the superior vena cava and the inferior vena cava. So superior vena cava is carrying the deoxygenated blood from upper parts of the body, especially from the head, neck, upper limbs. Everything, the deoxygenated blood from the upper part of the body is carried by the superior vena cava to the right atrium. Okay. Whereas inferior vena cava, the blood from the lower, deoxygenated blood from the lower part of the body is carried by the inferior vena cava. So, right atrium has 2 large veins. First is the superior vena cava, inferior vena cava. And deoxygenated blood from the right atrium enters the right ventricle via which valve? That is a tricuspid valve. In right part, we have the tricuspid valve. And deoxygenated blood from the right ventricle is carried to the lungs from the right ventricle. So initially, blood from deoxygenated blood is entering the right atrium via the superior and inferior vena cava. And after that, the atria contracts, and via the tricuspid valve, this atria is communicating with the right right ventricle. From the right ventricle, the pulmonary vein is carrying the deoxygenated blood that has already received from the superior and inferior vena cava. That is the deoxygenated blood. From atria, it is transmitted to the ventricle, and from the ventricle, the pulmonary artery, it carries the deoxygenated blood from heart to the lungs. Okay, for the oxygenation of the blood. So, from the lungs, the pulmonary veins, and after reaching the lungs, what happens is oxygenated blood is coming to the heart by means of pulmonary vein. So, pulmonary vein is only vein which is carrying oxygenated blood. Usually veins carry deoxygenated blood, but pulmonary vein that is coming from the lungs is carrying oxygenated blood. So, oxygenated blood is received in the left atrium via the pulmonary vein. And after that, the oxygenated blood from the left atrium, that is entering the left ventricle by means of mitral valve. So in the between the left atrium and left ventricle, we have the mitral valve, and between the right atrium and the right ventricle, we have the tricuspid valve. So after reaching, this oxygenated blood is coming to the left atrium via the pulmonary vein, and after that, it is reaching the left ventricle. From left ventricle, this oxygenated blood is carried to different parts of the body by means of arch of aorta. Okay. So, systemic arch of aorta arises through which the oxygenated blood is pumped throughout the body. That's the main crux of the cardiac pumping. or the blood circulation of the heart. So these are the mitral. We have the mitral or the bicuspid valve that is between the left atrium and the left ventricle, and the tricuspid valve, it is between the right atrium and the right ventricle, and we have semilunar valves which is associated with the pulmonary vein and the arch of aorta. Okay, pulmonary artery and arch of aorta. It prevents, these valves prevent the backflow of blood. Okay, so this is what I have already mentioned. This is the path of blood flow through the heart. Next is double circulation is a circulatory system where the blood passes through the heart twice in one complete cycle. In one cardiac cycle, the blood is passing twice. The deoxygenated blood is coming from different parts of the body, and after that it is reaching the lungs, and after oxygenation it is coming again to the heart for pumping to different parts of the body. That's why our human circulation is always called double circulation. So this is the double circulation. Now, these are the events of cardiac cycle. Okay, these are the events of cardiac cycle. Now, some points you have to note. First is the first event in the cardiac cycle is the atrial systole. That is atrial contraction. Systole means contraction. So initially, what happens is atria contract and small amount of blood enters. Initially, some amount of blood is present in the ventricles. Without any contraction, some amount of blood is already present in the ventricles. So here, for additional pumping, this atria is contracting and small amount of blood enters the ventricle. For the blood to enter the ventricle, the AV valves should be opened, are to be opened. So AV valves are open and semilunar valves are closed. Why the semilunar valves are closed? Because we have to make the blood reach the ventricle and not to the pulmonary vein. So the valve to the pulmonary vein is closed. So in atrial systole, what happens is AV valves are open, whereas the semilunar valves are closed. And the duration of atrial systole is about 0.11 second. Okay. Next phase is the isometric contraction. Isometric means the volume is not changing. So all the valves, whenever there is a word called isometric, then you have to remember automatically all the valves are closed in these phases. Whether it is isometric contraction or it is isometric relaxation, all the valves are closed. All the AV valves are closed. Semilunar valves, everything is closed in order to maintain the particular volume. Okay. So in isometric contraction, all valves are closed and pressure inside the ventricles is raised. Okay. Pressure inside the ventricles is raised. Why this pressure inside the ventricle is raised? In order to make the pressure above the pulmonary vein. In order to transmit the blood to the pulmonary vein. Next is ejection period. Ejection period, what happens is, so since the pressure inside the ventricle is more when compared to the pulmonary vein, what happens is semilunar valves have to be opened in order to pump the blood towards the least pressure side, that is towards the pulmonary vein. And the ventricles contract and the blood is ejected into the aorta and the pulmonary artery. And this period usually it lasts for about 0.22 seconds. Next phase is protodiastole. Here, the semilunar valves are closed and this is a very small phase before the starting of the diastole or the relaxation phase. This is only 0.04 seconds. Next is isometric relaxation. As I've already mentioned, the volume is remaining the same. In order to keep the volume same, all the valves are closed and the pressure inside the ventricle is reduced. And the duration is about 0.06 seconds. Next is rapid and slow filling. Here, the AV valves are open. The phase is again restarting. Okay. Ventricles relax and the filling of the ventricle occurs in rapid and slow filling. The duration is about 0.3 seconds. So these are the basic events of the cardiac cycle. This also you have to know very well or thoroughly you have to know this particular table and the events of the cardiac cycle. Next is, so this is what I already mentioned, this isometric relaxation, the ventricular pressure decreases greatly. And when the pressure becomes less than the pressure inside the atria, what happens is AV valves have to open, resulting in the rapid filling of the ventricles. Okay. So this is, so you have to think logically. Here, the atrial systole, what is the function of atrial systole? In order to fill the ventricle. Okay. So AV valves should be open. So the mitral and tricuspid valves are open and the blood should not backflow to the pulmonary veins or the arch of aorta. So the semilunar valve should be closed. And the status of ventricles and atria is atrial contraction is occurring in the atrial system. Next is isovolumetric contraction, in which what happens is volume is maintained and hence all the valves, whether it is AV valves or the semilunar valves, all the valves are closed. And the status is ventricles begin to contract. Next is ventricular ejection. In ventricular ejection, what happens is ventricle has to eject the blood to the pulmonary vein, and the left ventricle has to eject it to the arch of aorta. In order to do that, what happens is semilunar valves should be open in case of ventricular ejection. So here the pressure status is left ventricular pressure is more than the arch of aortic pressure, and right ventricular pressure, that is more than pulmonary arterial pressure. Next is isovolumetric relaxation. All the valves are closed and the semilunar valves, everything is closed. Next is the ventricular filling. Here, in order to fill the ventricles, the AV valve should be open and the semilunar valve should be closed. Here, the ventricle is relaxed. This is the pictorial representation of the above said events. So what is the duration of cardiac cycle? So the duration of one cardiac cycle is about 0.8 seconds. Okay. Now coming to the properties of blood vessel. So first is the cross-sectional area. The arch of aorta is a large vessel. We know that arch of aorta is larger vessel, but in systemic, when considered to the other smaller arteries, this arch of aorta cross-sectional area is less, because it is only there is only one arch of aorta, but there are multiple arteries and arterioles. So their cross-sectional area combined is more when compared to the arch of aorta. Okay. So aorta branches and the cross-sectional area of each individual vessel decrease, but collectively the cross-sectional area increases to reach a maximum in the capillaries. So the capillaries as a whole is having more cross-sectional area when compared to the arch of aorta. Next is velocity. So the velocity, it is inversely proportional to the total cross-sectional area. Okay. So given amount of blood is traveling through the more cross-sectional area, then what happens is velocity is reducing. So in arch of aorta, it is having a small cross-sectional area and hence the velocity is greatest. And in capillaries, it is having more maximum cross-sectional area and hence the velocity is minimum in case of capillaries. So coming to next property, that's a blood volume. So largest blood volume, it is present in this can be asked as MCQs. So largest blood volume is present in the systemic veins. And second largest blood volume is present in the pulmonary system. Next is resistance to blood flow. So resistance to blood flow is greatest in capillaries. Why? Because capillaries are having least diameter. When a single capillary is taken, it is having least diameter and hence the resistance to blood flow is more. Okay. Logically, when we think, we know that larger cross-sectional area, the vessel having larger cross-sectional area is having least resistance to the blood flow, since there is more space for the blood to flow. Next is hydrostatic pressure. It is usually least in the vena cava. Next is, what is a pacemaker? It's a part of heart from which the impulses for the heartbeat are produced. That is what we call as pacemaker. So what is a pacemaker of heart? That is a SA node or the sinoatrial node. And the position of the sinoatrial node is also asked multiple times. That is, SA node is situated in the right atrium, just below the opening of the superior vena cava. Okay. So it is located in the right atrium, just below the opening of superior vena cava. So we know that all or none law. We know that. What is all or none law? All or none law means in case of action potential, when the stimulus is reaching the threshold, all of the contraction of muscle fibers or whatever response is to be taking place as a whole. If the threshold is not up to the mark, then the response is not going to take place. Either it occurs fully or nothing will happen. That is what we call as all or none phenomenon. And all or none law is applicable for the whole of cardiac muscle, whereas in case of skeletal muscle, it is applicable only to the single muscle fiber. So here we can divide the systole into 2 divisions and diastole into 5 subdivisions. These are the time. You have to just know the time frame. Okay. So the total duration of the cardiac cycle is about 0.8 seconds. Now to have a rough idea of the this table, okay. These are not usually asked, but something is asked. The total duration of the cardiac cycle can be asked. Next is cardiac output. What is the cardiac output? Cardiac output is the amount of blood pumped from each ventricle. Okay. So total amount of blood pumped from each ventricle is called cardiac output. And it can be expressed in 3 ways. First is the stroke volume, second is the minute volume, and third is the cardiac index. So what is stroke volume? It's the amount of blood pumped by each ventricle during each beat. So heart is beating about around 72 times in a minute. Okay. So if one single beat, the amount of blood pumped, that is what we call as stroke volume. And minute volume is that it's the amount of blood. It's the amount of blood pumped out by each ventricle. 1 minute is what we call as minute volume. Next is the cardiac index. It is the amount of blood pumped out of a ventricle per minute per square meter of the body surface area. Okay. So, what is minute volume? Stroke volume is for a single beat. Minute volume is for the whole minute. So, stroke volume into heart rate is what we call as minute volume. So, what's the normal value? It is about 5 liters per ventricle per minute. So, and what is cardiac index? It is the amount of blood pumped out of the ventricle per minute per square meter of the body surface area. So, what's the average cardiac index is about 3 liters per meter square surface area per minute. So, these are the basic factors which are affecting the cardiac output. First is the venous return, that is simply the blood that is returning to the heart. The amount of blood that is returning to the heart, or the venous return, is in direct relationship with the cardiac output. Force of contraction. When the heart is contracting more forcefully, the cardiac output will be more. And the frequency of when heart is beating in much more frequency, that is much more frequently, what happens is cardiac output will be increased. Peripheral resistance. If the peripheral resistance is increased, then the cardiac output will be less. Okay. Also the preload. What is preload? Preload is the stretching of cardiac muscle at the end of the diastole. We know that when the blood is filling the ventricle, what happens is the muscles of the ventricles will stretch. In order to accommodate the blood, the muscles of the ventricle will stretch. There is one law called Frank-Starling's law, in which the initial stretch of the muscle is responsible for the force of contraction. It is directly affecting the force of contraction. If the initial stretch is more within the physiological limits, what happens is then the contraction will be more. That's what we call as Frank-Starling's law. So the stretching of cardiac muscle at the end of diastole is called preload. It depends upon if venous return is more, the preload will be more. And if the ventricular filling is more, then the preload will be more. And the force of contraction of the heart, cardiac output, extra are indirectly proportional to the preload. Then next is afterload. So afterload is that the force against which the ventricles must contract to eject the. So in order to eject the blood, the amount of force that is to be exerted by the ventricle is what we call as afterload. The afterload for the left ventricle, it is determined by that is when the aortic pressure, the ventricle has to push the blood towards into the aorta as well as into the pulmonary vein. When the pressure inside that particular vessels is more, the ventricle has to exert more amount of pressure in order to pump the blood towards that particular vessels. That is what we call as afterload. So, when in old age, etc., in narrowing of the arteries, the ventricle has to exert more pressure for the pumping of blood to different vessels. Okay, that is what we call as afterload. So, the afterload for the left ventricle, it is determined by the aortic pressure, and afterload for the right ventricular pressure, it is determined by the pressure in pulmonary artery. And also the force of contraction of the heart and cardiac output are inversely proportional to the afterload. Okay. So, this is the Frank-Starling's law. The force of contraction depends on the diastolic period. Also, the ventricular filling, preload and afterload. These are all dependent on the force of This force of contraction is depends on the diastolic period, ventricular filling, preload and afterload. Next is cardiac reserve. So the maximum increase in the cardiac output above, there is a normal value for cardiac output, above which the heart can pump with more amount of energy is supplied. The heart can pump more in addition to the normal cardiac output. That's what we call as cardiac reserve. So in normal healthy adult, the cardiac reserve is about 300 to 400%, about 3 to 4 times of by means of in emergency situations the heart can pump about 3 to 4 times blood than it usually pumps out. So cardiac output reaches a maximum during conditions like exercise. Okay, in exercise we need the heart has to pump more faster, so the cardiac reserve is utilized. And in cardiac diseases, the cardiac reserve is almost minimum or nil. Then coming to the arterial blood pressure. What is an arterial blood pressure? It is the lateral pressure exerted by the contained column of blood on the wall of arteries. That is what we call as arterial pressure. And it can be expressed as the systolic and diastolic pressure. So what is systolic pressure? It's the maximum pressure exerted in the arteries during the systole or the contraction of the heart. And diastolic pressure, it is a minimum pressure in the arteries during the diastole of the heart. Okay. So what is pulse pressure? This terminology is you have to know. Okay. Sometimes simple questions may be asked from this basic points or the base part of the subject. Some simple questions are asked, which usually students make mistakes in them. Okay. So what is pulse pressure? It is the difference between the systolic and diastolic pressure. Usually the normal value is about 40 millimeter of mercury. And what is MAP or mean arterial pressure? It's the average pressure existing in the arteries. And it is equal to the diastolic pressure plus 1/3 of the pulse pressure. So the formula for measuring the mean arterial pressure of MAP is diastolic pressure plus 1/3 of the pulse pressure. And the normal value is about 93 millimeters of mercury. So Frank-Starling's law, we have already mentioned. The force of contraction of heart is directly proportional to the initial length of eye. More stretching, more will be the force of contraction. That is within the physiological limits. Okay, within the physiological limits. Above that, the total thing is damaged. Okay. So when the force of contraction is more, the cardiac output is more, as also the systolic pressure rises. So these are the crux of Starling's law of heart. Increase in the force of contraction is directly proportional to the cardiac output. Also, the force of ventricular contraction, that is also directly proportional to the end diastolic volume. Also, the energy of contraction, that is also directly proportional to the initial length of the cardiac fiber. These are all assumptions which can be derived from the Starling's law of heart. And for the heart, the length of muscle fibers or the extent of preload is directly proportional to the end diastolic volume. Another law that is called Mary's law, that is heart rate is proportional to the, inversely proportional to the blood pressure. Okay. So next is heart sounds. This table is very important. Numerous questions are asked from this particular table. Okay. You have to learn it very carefully. So heart sounds. So the first heart sound, it is occurring during the isometric contraction and part of ejection period. What's the cause of first heart sound? It is the closure of it's a sound produced due to the which can be appreciated by means of a stethoscope. The closure of AV valves cause the first heart sound. What's the characteristic features of the first heart sound? That is long, soft, and low pitched, and it resembles lub sound. Okay. Usually, what's the relationship with the ECG? It coincides with the R wave of the ECG. Second is second heart sound that occurs during the protodiastole and part of isometric relaxation. The cause of this sound is closure of semicircular. This is asked in Comet K 2013, and multiple questions are asked from this particular table. Okay, so what are the characteristics? They are short. Second is short, sharp, and high pitched sound. It resembles a dub. And usually it appears after 0.09 second after the summit of T wave. And third is occurs during the rapid filling and rushing of blood into the ventricles is the cause of third heart sound. It is low pitch sound and it is seen in relationship with the ECG, it is seen between the T wave and P wave. And fourth is the atrial systole, that occurs during the atrial systole and causes the contraction of the atrial musculature. Usually, this fourth sound is almost inaudible and it occurs between the P wave and the Q wave of ECG. Now coming to the ECG. What is an ECG? It consists of waves, complex intervals and segments. So it is usually the waves of ECG is recorded by the limb lead 2. They are considered as typical waves. It can be asked as an MCQ. And normal ECG has, we know that P waves are there, QRS and T waves are there. These are the normal waves of ECG. So this is the image of ECG. In a heart with normal sinus rhythm, lead 2 is usually taken for recording the ECG. So this is very important. This also asked multiple times. So P wave is due to the atrial depolarization. You can remember it as ADP. So atrial depolarization is the cause of P wave. QRS complex, it is due to the ventricular depolarization. T wave is caused by the ventricular repolarization. And U wave, it is a rare and insignificant wave of ECG, and it is due to the repolarization of the, you have to be thorough with this terminology. What is depolarization? What is repolarization? Everything you have to study. Okay. So, repolarization of the papillary muscle is producing the U wave. What is PR interval? It is the onset of P wave to the onset of Q wave is called PR interval. Usually the cause is atrial depolarization and conduction through the AV node. And QRS duration, it's the onset of Q wave and end of S wave. Ventricular depolarization is the cause of QRS. And QT interval, it is from Q wave to the end of T wave. It is due to the electrical activity of in ventricles. And ST segment, it is the end of S wave to onset of T wave. Now, what is a murmur? Murmur means it is produced, it's a sound produced due to the turbulence of blood flow inside the heart. Okay, other than heart sounds, due to the turbulence or the rapid flow of the blood is causing this murmurs. So we have, basically it can be divided into systolic murmurs, diastolic murmurs and continuous murmurs. Systolic murmurs, the causes are the incompetence of AV valves, stenosis of semilunar valves, anemia, septal defect, coarctation of aorta. These are all causes of systolic murmurs. And diastolic murmurs, it can be due to stenosis of AV valves, incompetence of the semilunar valves, and continuous murmurs can occur in the patients with patent ductus arteriosus. Now coming to symptoms, this is asked in the previous year question also. What is Stokes-Adams syndrome? Its survey called cardiac syncope. And it is due to the total AV block suddenly begins and the duration of the block may be a few seconds or even several weeks. Okay. The patient becomes unconscious. Okay. During the Stokes-Adams syndrome. And in Wolff-Parkinson-White syndrome, it's a congenital condition in which the heart rate is increased in such patients. It's congenital syndrome in which the heart rate is raised due to the increased signaling pathways. The electrical circuit is firing more in case of Wolff-Parkinson-White syndrome. It's a congenital syndrome. Okay, so the heart rate will be raised in WPW syndrome or Wolff-Parkinson-White syndrome. Next, coming to some MCQs. First is when a person lies down, what happens? When a person lies down, the options are there is immediate increase in the venous return. Second option is the heart rate becomes stable at slightly more than normal. Third is cerebral blood flow increases and becomes stable at more than normal. Fourth is blood flow to the apex of lung decreases. Just read the question and frame an answer. So what's the answer? There is an immediate increase in the venous return. Why? So when the person is lying down, there will be increase in venous return. Why? Because while standing or sitting, what happens is the blood is pooling in the lower extremities. When lying, what happens is blood is returning back from the lower extremities. That's why the venous return is increasing when lying down after a prolonged standing. So standing after sitting or lying decreases the cardiac output as much as 20% due to the pooling of blood. While standing, what happens is blood is pooling in the lower extremities. About 20% of the cardiac output is reduced while standing. When we lie down or sit back, what happens is this blood is pooling. This blood is also returning to the heart. That is pooled inside the extremities. So about 20% increase in cardiac output is occurring. Next is Starling's law of heart. The options are does not operate in the failing heart, does not operate during exercise, explains the increase in cardiac output that occurs when venous return is increased. Fourth option is explains the increase in cardiac output when the sympathetic nerve supplying the heart is stimulated. What's the answer? So it explains the increase in cardiac output that occurs when the venous return is increased. We know that stretch rate, initial length of the muscle fiber is proportional to the cardiac contraction. So it explains the increase in cardiac output that occurs when the venous return is increased. This we have already learned. Second heart sound is characterized by all except. First option, due to closure of semilunar valves, is occasionally split, has longer duration than the first heart sound, marks the onset of diastole. So except is what they are asking. So the answer is has longer duration than it. It is having shorter duration when compared to the first heart sound. So the answer here is has longer duration than the first heart sound. Another question. The first heart sound is produced by the, we know that it's a closure of mitral and tricuspid valves are causing the first heart sound. Isovolumetric relaxation ends immediately after. The options are AV valve closes, when ventricular pressure falls below the aortic pressure, when ventricular pressure falls below the aortic pressure, none of the above. The answer is when ventricular pressure falls below the atrial pressure, what happens is that the ventricle is pumping the blood towards the aorta and pulmonary vein. In cardiac cycle, the pulmonary valves open when? The options are end of diastole, beginning of systole, end of isovolumetric relaxation, end of isovolumetric contraction. So the answer is end of isovolumetric contraction. So another question is a closure of aortic valve occurs before the isovolumetric relaxation. Okay. Now, next question, absolute refractory period in heart. The options are last till cardiac contraction, longer than the refractory period in skeletal muscle, a phase of cardiac cycle in which heart cannot be stimulated by any amount of stimulus, corresponds with the duration of the action potential, all of the above. So the answer here is all of the above. So by learning this question, you can frame multiple questions. Okay, these are all different points. So absolute refractory period in heart, it lasts till the cardiac contraction. It is longer than the refractory period in the skeletal muscle. That's also right. A phase of cardiac cycle in which heart cannot be stimulated by any amount of stimulus, and it usually corresponds with the duration of the action potential. So what's the difference between absolute and relative refractory period? So absolute refractory period begins with the depolarization and extends into the final repolarization phase. During the absolute refractory period, the cardiac muscle is completely insensitive to any amount of stimulation. Any amount of stimulation cannot provoke the heart. Okay. And relative refractory period occurs during the last part of the final repolarization phase. Now coming to the next question, stimulation of baroreceptors leads to. The options are, the answer is already there. So decreasing BP, decreasing heart rate. So when the pressure is increased, what happens is the baroreceptors or the pressure receptors will be having appreciating that particular situation. It is sending the response to the higher centers. So it will reduce the BP and reduce the heart rate. That's a function of baroreceptors. The function of carotid body. Carotid body is a chemoreceptor. So it measures the change in partial pressure of the oxygen in the arterial blood. If that is low, it will try to increase the blood pressure. So rapid increase in the arterial blood pressure, what happens is the baroreceptors in the carotid sinus are stimulated. This in turn stimulates the cardio-inhibitory or the vagal center inside the brain, and it suppresses the vasomotor tone and thereby reducing the blood pressure. Heart rate, force of contraction, and peripheral resistance are decreased, and cardiac output and the arterial blood pressure are also reduced. So inactivation of the, and that will lead to the, if the everything is reduced, then the baroreceptors will be inactivated. So, what's the location of carotid body baroreceptors? It is located in the internal carotid artery. Origin of internal carotid artery, this carotid body or baroreceptors are located. So, also they are found in the wall of arch of aorta. So, what are Trobe-Herring waves? So, there are fluctuations in the blood pressure. It is synchronized with the respiration. So, the fluctuations in the blood pressure that is synchronized with the respiration is what we call as Trobe-Herring waves. The largest function of total peripheral resistance is due to. The options are venules, arterioles, capillaries, precapillaries, sphincters. That is in the arterioles. So, total peripheral resistance is inversely proportional to the radius. If the radius is more, then the resistance will be less. Okay. So, that is why the radius is minimum in arterioles. Sorry, radius is minimum in arterioles. So, TPR will be more in arterioles. So, peripheral resistance is maximum in arteriole. Next question. A 65-year-old male patient visited to the doctor for chest pain, and on examination, his BP was measured as systolic, about 190, diastolic 100, heart rate 74 per minute, pulse pressure 90. Decrease in which of the following explain for high pulse pressure? So we have to notice the patient is an aged patient, is having 65 years. So the options are arterial wall compliance, stroke volume, cardiac output, myocardial contractility. What's the answer here? It's the arterial wall compliance. The compliance is reduced in case of aged patients. So, aging impacts the pulse pressure and arterial compliance. With aging, what happens is decrease in the compliance of the large elastic arteries due to the loss of collagen. Elasticity is lost for the arteries. Okay, decrease elastin content, decrease collagen 1 deposition and the calcification. This will lead to the stiffness of the wall. So, it will lead to the hardening of the arteries. So, the pressure the ventricle has to exert through the to pump through these vessels is increased, and the left ventricle contracts against the stiffer, less compliant arteries. Systolic and diastolic pressure increase. That's the cause of widened pulse pressure. Both systolic as well as diastolic pressures both will increase, and it will lead to the widening of the pulse pressure. And left ventricle due to the excess workload, it can lead to hypertrophy. Left ventricular hypertrophy can occur. When excessive pulse pressure transmits through the microcirculation of vital organs like brain and kidney, extensive tissue damage can also occur. A widened or larger pulse pressure occurs in several diseases like aortic regurgitation, aortic sclerosis. They are a hardening of the arteries, and severe iron deficiency anemia also, this pulse pressure widening will be occur. Okay. Because of the reduced blood volume, ventricle has to pump more. That's the reason for this widening of pulse pressure in iron deficiency anemia. Okay. So, increased functional demand on the heart produces increased size of the heart myocardium by means of hypertrophy. Okay. Hypertrophy means increasing size of cells, not, and hypoplasia means increasing number of cells. Okay. So, increased functional demand is met by the heart by means of hypertrophy. Next question. The dicrotic notch on the aortic pressure curve is caused by. The options are closure of the pulmonary valve, rapid filling of the left ventricle, closure of the aortic valve, contraction of the atria. What's the answer? Closure of the aortic valve. So, what is a dicrotic notch? It's a small oscillation on the falling phase of the pulse wave. It is due to the vibration setup when the aortic valve is shut. Okay, when the aortic valve is shut, what happens is there is a vibration occurring and it will cause a small oscillation in the falling phase of the pulse wave. That is what we call as dichrotic notch. It is usually visible when the pressure wave is recorded, but it is not palpable in the wrist. And the pulmonary artery pressure curve also has dichrotic notch. It is produced by the pulmonary artery pressure curve also has dichrotic notch. It is produced by the closure of the pulmonary valves. Next question, cardiac output is not affected by. It's a simple question. The options are heart rate, peripheral resistance, systolic blood pressure, venous return. Not affected by. Answer is systolic blood pressure. So what is a cardiac output? It's a measure of heart rate into blood volume. So thank you for your patient listening. These are the main topics that are covered in our video. You can also read more from the text. Nowadays, the questions are asked very deep in a deep format. Multiple choice, not multiple choice, actually match the following. Also, multiple options are there, and then they are asking A and B are right. For that for solving that type of questions, you have to be clear and deep knowledge in the theory part also. Okay. So the old model is rapidly degenerating, and now new questions, they are framed by new experts. So this type of questions are a bit difficult, and deep knowledge in the theory is essential for solving such type of questions. So thank you for your patient listening. Good night.